All right. So thanks everyone for sticking around. I'm Omid Mehdizadeh. I'm a laryngologist, ENT, specializing in voice and swallowing disorders. And with that, I see a lot of patients who I believe you see as well with chronic cough, globus, throat clearing. So let's go ahead and start. So, we see a lot of these patients coming in and into our offices, just a lot of throat irritation. Sometimes this is all encompassing, both psychologically and physically. They're unable to eat, they're losing weight, and we can't quite figure out what's going on with these patients. So a lot of this not quite effective throat clear and block, and obviously a lot of us are feeling this as well. So common symptoms associated with this condition include just a lump in the throat, mucus sensation, tightness. These are just a few of the symptoms that we're hearing. Interestingly, a lot of these patients say they can't swallow. Although they're not drooling, they're not losing weight, some of them, and they're able to eat and drink quite easily without signs of aspiration, but the common sensation is that they're unable to clear their mucus from their throat. We create approximately 1 to 1.5 liters of mucus a day, so patients always come to me and they sometimes show a picture of what they're clearing, which is either white mucus or clear mucus, and they say, but there's mucus down here, and I try to explain to them that that's normal. In order to clear that mucus, we are swallowing approximately 500 to 700 times daily. Obviously, much of this is automatic and autonomic and neurologic, and we're not quite appreciating that. Globus, I titled this Hystericus differentius. So first described by Hippocrates about 2,500 years ago, so a lot of us have been throat clearing since then. And then in the 1700s, they actually did describe, some researchers actually did describe an esophageal etiology to the globus, but that was quickly dismissed. And much of the 1700s, 1800s, as well as early 1900s, the condition was attributed to psychosis, anxiety, and hence they titled it Globus hystericus. But starting in the early 1900s until now, we're learning more and more about how this is actually a physiologic process and associated with actual organic underlying conditions. So I know this is a busy list here, but I just wanted to kind of bring up some of these. So of course the causes are numerous, and anything from psychogenic and anxiety to actual esophageal or laryngeal or any upper aerodigestive tract cancer. And it's our job to try to figure out which one this is. And of course it can be quite daunting sometimes, but fortunately there are some red flag symptoms that allow us to identify etiologies early on. Interestingly, one study about 15 years ago showed that about 4% of globus is associated with an esophageal malignancy. Now, I think that's an overestimation. However, again, it brings light to some interesting aspects that we should consider. Going down the list, of course, allergic rhinitis associated with their common allergy symptoms. Even a tonsil stone can be associated with globus sensation, and I've seen many patients, as soon as they express the stone, everything feels better, life is better. Esophagitis and gastroesophageal reflux has been noted to be cause approximately 50% of globus. So a near substantial majority of these are esophageal in etiology, and sometimes the upper aerodigestive tract and laryngoscopy and the upper airway is perfectly normal. They don't have allergy symptoms, they don't have turbinate hypertrophy. When we do a laryngoscopy, their larynx looks perfectly normal. So it's quite interesting that many of these sensations can be referred up to the throat. In fact, kind of going along with dysphagia, many of our patients describe solid food dysphagia with food getting stuck inside the throat. In fact, half of those patients, the food is actually getting impacted in the distal esophagus. So we're not very good at describing where these sensations are coming from, further kind of making this a little bit more of a difficult diagnosis. I think something that's interesting and something that's also overcalled is thyroid, especially thyroid nodules. Unfortunately, in my fellowship and in my practice, I have seen patients undergo thyroidectomy. It's actually a good follow-up on Dr. Walgama for benign nodules on the order of 1.5 centimeters. and practitioners believe that that was actually the cause of the globus sensation. And I want to urge a lot of us to say that unless the thyroid goiter is actually causing compressive symptoms of difficulty breathing, difficulty swallowing, I would be very hesitant to remove a benign nodule just for the sensation of globus. Of course, adenoid hypertrophy, sinusitis. There are some medications that can cause a sensation of globus, or specifically increased chronic cough as well, such as ACE inhibitors. We're all very familiar with those. Other medications are anticholinergics as well. Those are notorious for causing these sensations. Some medications can cause esophageal inflammation, like tetracycline, clindamycin, doxycycline, and that could cause a severe globus sensation as well as throat clearing. Other medications like Januvia can cause significant gastric stasis or decreased gastrointestinal motility, increasing gastroesophageal reflux as well. Of course, we're all familiar with bisphosphonates causing severe acid reflux. Tricyclic antidepressants can cause delayed gastric emptying as well. Other causes of esophagitis would include CMV, HSV, fungal esophagitis that we see commonly in our immunocompromised patients, and many of these patients do describe a globus sensation as well. I put up here a picture of the cricopharyngeus muscle. So what you can see here is the cervical spine, the clavicles. This is barium, contrast material sitting within the pharynx. The patient's pointing there to the left. The back of the head is up here, and here's the chest. Here's normal barium contrast in the throat, and here is the cricopharyngeus muscle, which is essentially part of our upper esophageal sphincter. Limits what we think it's due to, what we think it's there for is to actually naturally prevent gastroesophageal reflux contents into the throat. So when we swallow, that muscle is supposed to relax and food's supposed to go down easily. But here's an image of the muscle not relaxing, but actually a pretty severe obstruction. This has been associated with just globus sensation, of course, with dysphagia. However, a study out of China showed that there was a statistically significant association between people who had anxiety and increased upper esophageal sphincter pressures. So we don't know which is which. Is it the actual something neurologically is going on with that muscle and they have this chronic sensation of globus, or is it the I have a lump in my throat because I'm nervous and that's what's causing that sensation? So interestingly, there is a physiologic explanation to the symptom. Moving on. So I put a bunch of other things here as well. So, if you have very large cervical hardware sitting right behind the pharynx, that can give you globus sensation as well. Anything going on within the throat, like a pharyngeal, a pharyngeal cyst, laryngeal cyst. I think muscle tension dysphonia is a big one that's under-recognized. So tension in the throat and especially in the larynx associated with hoarseness. People get a lot of muscular tension, a lot of tightness, and that could be quite debilitating to them as well. One thing that I'm going to focus on here is going to be superior laryngeal nerve neuropathy, which is what we suspect is a traumatic or post-viral cause of inflammation to the main sensory nerve that goes to the larynx, causing chronic throat clearing, globus, as well as chronic cough. So kind of pointed out some things with regards to globus and essentially with chronic cough. Very similar picture here. So the two really do overlap in terms of symptoms and patient complaints. So approximately 20 years ago in the laryngology literature, this concept of the irritable larynx came up, which is similar sensations, again, throat clearing, cough, difficulty swallowing mucus. And I like to think of this as a spectrum, anywhere from I have a lump in my throat sensation to I just can't stop coughing. Most of the time, or actually predominantly, if this is a neurogenic type cough, i.e. like a vocal cord spasm, it should be a dry hacking cough. Any cough that is wet should raise other types of suspicions. So other terms that we use to describe this type of throat irritability is a neurogenic cough, vagus neuropathy, as the superior laryngeal nerve is a branch of the vagus nerve, irritable larynx syndrome. Interestingly, we probably took that from our GI colleagues, as well as vocal cord dysfunction. So some of these patients may describe the inability to breathe. I'm sure some of you have seen patients that have developed severe stridor and a choking sensation. Some have actually gone to syncopize, and that could many times be from an actual paradoxical motion or vocal cord spasm. Mechanisms, quite unclear at this point, but from a neurogenic perspective, we think it's a hyperactivity of the sensory fibers in the upper airway, specifically the alpha and C fibers. And I'm going to actually talk about some medication or a medication that's actually being studied currently to try to suppress that. Many different types of evaluations, so questionnaires. So if we were trying to understand what's causing this, a reflux severity index to understand whether this is associated with LPR, cough severity index, how severe is this, reflux findings within the larynx, as well as whether the patient is actually also developing voice issues, and that could suggest a vocal etiology as well. I'll show some videos of this in my next talk, but video stroboscopy, specifically video stroboscopy, compared to laryngoscopy, I think is actually crucial in diagnosing and excluding other causes of Globus. Esophagoscopy, to piggyback on Dr. Butler, we're actually, you can actually perform an esophagoscopy in the office, at the very least an awake patient under local anesthesia, and this is with the advent of a transnasal esophagoscope under just applying a little bit of lidocaine spray to the nose and going all the way down into the stomach. We can't evaluate the small intestine as these are shorter scopes, but they are much narrower and they are channeled scopes, so we could do interventions, Botox injections, biopsies, as well as steroid injections right in the office, and it's quite remarkable that patients get a complete upper airway digestive tract evaluation in 15 minutes. Imaging, of course, chest x-rays, neck imaging, in specific cases, chest CTs as well. I work closely with our pulmonology colleagues in order to rule out asthmatic cough, eosinophilic cough, pulmonary function tests, of course, to rule that aspect out. And I think pH studies are crucial, as most of these patients' symptoms are due to either LPR, laryngopharyngeal reflux, or GERD. Treatment is, we typically start with treating that, but ultimately, if we can't find the cause, we do move on to pH studies. Common pH studies would include like a 24-hour impedance study, just a small catheter that goes through the nose and sits in the stomach. A little bit uncomfortable for patients because it is a 24-hour study. They do go home and they have a small wire sticking out of their nose for that period of time. But I think it's very helpful. The benefit of that is, I'll explain the benefit in just a second. There is another type of pH study that's called Bravo, and there is no external wire. This is a small pH monitor that's placed into the distal esophagus endoscopically. So benefit of that is that the patient has no idea that there's something there. The disadvantage is that they do have to undergo a moderate sedation and endoscopy to place that probe. The benefit of, again, ambulatory pH is that they don't have to do that. Another benefit of it is that Dr. Griffiths earlier alluded to non-acid reflux. So we have a lot of these patients who don't respond to PPI therapy, yet they're still having these symptoms. So ambulatory pH actually has a special type of catheter that can measure just volume reflux, not specifically acid reflux. And that gives rise to this whole idea of pepsin and pepsinogen in the upper airway causing symptoms. Ultimately, it is a digestive enzyme. So what is it doing up in this area? I have seen some people use like cheek swabs for pepsin. I think the research is not quite convincing of whether that's quite specific or sensitive in diagnosing these types of conditions. And ultimately, high-resolution manometry. So if we're trying to evaluate for pressure issues, motility issues, like I showed earlier, that cricopharyngeus muscle, the hypertone, the hypertonicity of that muscle, or whether this is some type of ineffective esophageal motility, like nutcracker esophagus, esophageal spasm, hypertensive esophagus, that would be the study of choice. So in terms of treatment, let's say we've ruled everything out. And now we're left with the point of what we would call idiopathic. I start moving my patients towards this idea or notion of the superior laryngeal nerve neuropathy or chronic hypersensitivity, or neuropathic cough. So tricyclic antidepressants, namely Elavil, have been helpful, especially with nighttime symptoms. These patients are waking up with a cough. Gabapentin can also be quite effective. I tend to shy away from opiates just because of the risks associated with them. The over-the-counter medications, it's a multi-billion-dollar industry. You know, we walk to the pharmacy, just a huge area on allergies, reflux, cough. So that's a huge industry as well. How effective? Not quite sure. I don't think it's that effective ultimately for chronic cough. And then we are, with our speech-language pathologists, we move towards actual therapy for retraining this hypersensitive larynx. So there's respiratory retraining therapy, cough suppression therapy, that has a lot to do with avoiding triggers, as well as specific breathing techniques. I also utilize botulinum toxin to reduce the spasticity of the vocal cords, as well as superior laryngeal nerve cough. I'll move through this quickly, but essentially these are some studies that have shown the procedure called superior laryngeal nerve block for treating the neurologic hypersensitivity in the throat. So this was initially used by our anesthesia colleagues for awake intubation. In patients that couldn't undergo actual general anesthesia, they would block the superior laryngeal nerves within the neck, and that would cause complete laryngeal numbing. So we've actually found that blocking this nerve in the office has reduced chronic cough, globus, throat clearing, in settings of superior laryngeal nerve neuropathy. Quite easy to do, just identifying laryngeal landmarks, injecting right into the membrane between the Adam's apple or the thyroid notch and the hyoid bone. And I like to inject triamcinolone or Kenalog, as well as Marcaine. For some patients that we're not quite sure whether that's going to be helpful, I just go ahead and inject 2% of lidocaine. Risks, the 3 out of 60,000 patients have shown to develop blindness associated with any type of Kenalog injection in the head and neck, specifically for the turbinates, and that's specifically due to the particulate of the steroid going intra-arterial and eventually traveling to the brain. So we could do things technique-wise to avoid that. Some centers inject up to 6 times. I personally inject 3 times max on both sides since we don't know much about it. But I have seen patients come into the office miserable. They can't talk. They can't swallow. They're constantly clearing their throat. They feel like there's something there. You do 1 block and they're happy within a few weeks. So it's quite a remarkable thing that we've started to do recently. So just want to open up for questions. Otherwise, I'm happy to move on to the next lecture. Great. So this one's going to include a lot of videos. I think just, they say a picture is worth 1,000 words, so we'll move quickly through that as well. So hoarseness, any condition that alters normal vocal cord physiology. I think this is an area of our anatomy that not many of us see. We don't really know what's going on down there, so I kind of wanted to open this up to just show you guys what I see on a regular basis and how you can apply this to your practice. So when I show my pictures that are laryngoscopy in the office, I get responses from gross to wow, as well as G-rated to X-rated comments on what this could potentially be. But just to orient you, the top of the screen is the posterior pharyngeal wall. Left is right and right is left. So we're looking straight down the larynx here. The arytenoid cartilages are essentially the joints that control the motion of the larynx. They can move along an x-axis, up and down, y-axis, and they could also actually rotate as well. So there's over 6 paired muscles controlling each vocal cord. So you could imagine that's what's responsible for such our profound ability to produce voice. The vocal cord is made up generally into 3 layers, what we call the body cover theory. So the deepest layer, which is most of the slide here, the histology here, is the vocalis muscle, which is what's responsible for shortening and elongating the vocal cord. There is a layer called the lamina propria between the blue epithelium and the muscle. And that is made mostly of a gelatinous matrix as well, and that's what allows the vocal cord epithelium to essentially vibrate and create the frequency or the fundamental frequency of our voice. Just want to differentiate voice from speech. Of course, we have a lot of therapists who perform speech therapy in children, and that is due to our throat, our tongue, our soft palate, especially our lips and our mouth, but specifically voice production has to do with the larynx. So here's a normal laryngoscopy. Patient's breathing and saying E. So that's an E sniff with the vocal cords closing and the vocal cords opening. And then I want to show you what vocal cord function is without stroboscopy. So there you could just see the patient saying E. I'm just going to show you that again. So E, you can see that they're coming together, they're closing, and they're opening normally. But as soon as we introduce this special camera and light source, not camera, but light source called stroboscopy, you can actually, I think that's coming out pretty dark, right? Okay. Can you guys see that? I can't tell. No? Okay. Well, anyway, what stroboscopy does is stops the image of the vocal cord vibration at each stage of its vibration. In men, the epithelium glides back and forth approximately 120 to 140 times per second. In women, it's a little bit higher, 180 to 200 times per second. And stroboscopy, imagine it like a high-speed camera. It freezes the frame at every part of that cycle, and via just some algorithms shows us that glide of the vocal cord. And it's quite remarkable because it could show things that we wouldn't see otherwise. So just some common symptoms of hoarseness or common complaints: hoarseness, rough, weak, strained, muscle tension. And just some common acute causes. Of course, we all see viral laryngitis, self-resolving within 3 to 5 days. Every once in a while, we can see a superimposed bacterial laryngitis, typically from either like severe tonsillitis or severe sinusitis with the bacterial stuff draining down into the throat. This is an example of a vocal cord hemorrhage, so a ruptured blood vessel underlying this epithelium here. You can see the hemosiderin or the blood deposits there as well. And of course, voice misuse, overuse, going out to the clubs, to the bar, shouting, talking a lot. We all have gone home the next day, have had a lot of hoarseness. Not all of us maybe, but tends to happen. Of course, with any hoarseness, red flag symptoms: difficulty swallowing, difficulty breathing, stridor, of course, blood in the saliva, and usually any systemic findings that aren't usually analogous with an upper respiratory tract infection. Chronic hoarseness, any hoarseness lasting greater than 3 weeks. So if you find it's associated, again, with any of these symptoms, I would recommend more urgent referral or at least evaluation rather than just sitting on it. So in terms of the laryngeal aspects here, so things that I see quite commonly, again, laryngeal pharyngeal reflux, nodules, polyps, and cysts, vocal cord paresis, which is similar to vocal cord paralysis, but much more subtle at times, infectious, something that I think is quite under-recognized, the aging voice, especially in our population greater than 65, neurologic conditions, systemic, such as TB, sarcoidosis, rheumatoid arthritis. These can all present in the larynx as well as cancer. So just because we've talked about this a little bit, I'm going to move on from here. So just kind of wanted to show you what an inflamed larynx can look like. Here, if you can remember kind of what the last one looked like, here you can see how things are generally so much more swollen. The back of the vocal cords is edematous. The vocal cords themselves are swollen. The actual esophagus is back here, so you can imagine that any type of reflux coming out here is really just going to be in this area. So again, edematous vocal cords and just a really swollen voice box. And you can imagine how people can come in and say, I feel like there's a ton of mucus sitting in my throat, and when you look down there, there's no mucus. Or abnormal mucus, but it's actually quite swelling. And unfortunately, it's difficult to educate patients on this aspect because they'll still continue to clear their throat, and you can imagine the more throat clearing they do, the more inflammatory that will be, and it's just this chronic snowball of effects. So we really try to break the cycle in a lot of these patients to get them to feel better. Same thing with chronic cough. We tend to, quote unquote, give in to the cough when we get these neurogenic coughs. So if we can at least try to break that cycle, a lot of times it could go away on its own. Here's an example of a traumatic or hemorrhagic polyp in a patient. So this is actually quite a large polyp on the left vocal cord. Treatment for these is surgical. Unfortunately, when they get this big, they don't tend to go away with voice therapy. So we take these patients to the OR through the mouth. Nothing is done externally, and do a microflap or a very meticulous dissection between healthy and abnormal vocal cord and remove that under the microscope. Smaller polyps can be treated with voice therapy. However, this size, I definitely would not recommend it. Vocal cord nodules, see them all the time, typically in people who need to talk a lot, lawyers, teachers, of course, singers, younger patients who are going to school and are generally social people. By definition, nodules are always bilateral. Think of these as a callus. You know, you wear a bad shoe, you walk all day, you get a callus on your foot. Well, if someone's talking all day or misusing their vocal cords, creating a lot of tension, they get these bilateral thickenings of the actual epithelium of the vocal cord. These are very dynamic in that if you stop talking for 1 to 2 weeks, they tend to go away. Psychologically, we can't ask our patients to stop talking for 1 to 2 weeks, especially if that's the reason they're occurring in the first place. So that's why the help of our speech-language pathology, our voice therapists, are quite crucial in the treatment of these pathologies. This is an image of a patient with aging voice. So here you can see that the vocal cords are no longer straight and linear, and when they come together here in the posterior aspect, there's still a large gap along the anterior aspect of the vocal cord. So we see these in about a quarter of patients over the age of 65. Very common, and a lot of my patients at this age who are actually quite active describe kind of lack of confidence, emphasis, authority in their voice. And these are relatively easy to treat. So we can treat these with voice therapy, basically teaching patients how to emphasize their voice from a diaphragmatic and a pulmonary aspect, reducing the tension in the neck and the throat, to in-office injections, as Dave had alluded to. So most of these procedures are, again, done in the office under local anesthesia. We put a scope down the nose, visualize the larynx, get a filler material, either materials that last anywhere from 2 months to a year and a half, going through the skin of the neck, put the needle here directly into the vocal cord and inject the filler, and that medializes the cords and allows them to come together. So vocal cord paralysis, very common voice in these type of patients, very breathy, very weak. Some may actually present with liquid aspiration of liquids because the vocal cords are unable to come together completely. Most common cause is iatrogenic or surgical. Other common causes would be idiopathic. We think it's post-viral, but not quite sure. Most of those do recover within 6 months. 90% of those do recover within 6 months. And other causes like a stroke, trauma, as well as, of course, the most important thing to rule out here would be some type of neoplasm. So any type of mass that's encroaching or putting pressure on the recurrent laryngeal nerve can cause this type of issue. And that recurrent laryngeal nerve runs anywhere from the skull base down into the chest. So we typically do engage in imaging to rule those aspects out. And again, these patients don't need to walk around with a very breathy voice. They do benefit highly from an in-office augmentation to treat their condition. I'll skip this one for now, since I don't think you guys could see it anyway. Vocal tremor, this is really interesting. So essentially we can develop an essential tremor of our voice box as well, similar to an essential tremor of our extremities. Unfortunately, medications used to treat extremity local essential tremor are not that effective for the throat. So we tend to send these patients for voice therapy because that can be effective. But a wonderful treatment for these patients is botulinum toxin or Botox into the larynx. It's quite remarkable. The doses that we start with are fractions of normal doses. So typically in my elderly patients, I'm using 0.0625 units to begin, and I incrementally increase by 0.25 units. So average dose about 2.5 units into each vocal cord, and it does substantially improve their tremor. So I want you to kind of see it here. So you could see this kind of fluctuating muscle spasm. Show you that again. So you can see how dramatic it can be. And the more anxious the patient gets about this voice, the worse it gets. So unfortunately, again, it's one of those things that just compounds on itself. So many of these patients describe having a Xanax or having a glass of alcohol, and it tends to go away. But again, we tend to inject the Botox directly into the vocal cords, again, in the office, and it significantly reduces the tremor. Adductor spasmodic dysphonia is also something, spasmodic dysphonia is also something that I think is under-recognized and we can treat quite easily. These are patients with a very spastic voice. I have a video, but we won't go ahead and look at it right now. But essentially, these patients have breaks in their speech. So they talk like this. And that's a pretty dramatic example. So you could think of this as a vocal dystonia, again, an inappropriate spasm of the vocal cord. You could have this affecting the vocal cord muscles that are meant to close the vocal cords, and that's when they have a very spastic, tight speech. Sometimes it actually can affect the muscles that open the vocal cords. In that case, these patients can have a very breathy voice. And these can be identified on specific vowels and syllables in the office. Some cases, it's mixed, and these pathologies are primarily treated with Botox. Just wanted to bring your light to this. This is a patient that came to me. Her chief complaint, she was referred to me with hoarseness. Just wanted to see that not all hoarseness is vocal cord, but this is subglottic stenosis here. So if you watch her saying E and then open, you can see that significant and large scar band right in her vocal cord, so right there. So here are the cords. That's the scar band right there, and that's her airway back there. Yeah, so again, the referral for this patient was hoarseness, not stridor, not difficulty breathing. So these tend to occur either via intubation, traumatic. There is a large cohort of women, typically Caucasian, starting in their 40s to 50s, developing idiopathic subglottic stenosis. We typically treat these in the operating room with dilations, lasers, as well as steroid injections. And lastly, squamous cell carcinoma, of course. So most of these patients are nearly asymptomatic, especially if it's early stage glottic cancer, except for hoarseness. They don't have any difficulty swallowing. They don't have pain. They may have a little bit of a cough, but again, they come in with hoarseness. And we have very special types of light that could actually pick up on irregular lesions. So the green here you see is a special type of light called narrowband imaging, which allows, and I think the gastroenterologists use it as well, and allows us to evaluate the vascularity of the mass, differentiating between benign, or at least suggesting whether this is a benign or malignant process. So that's all I have for you guys today, and if I could invite any questions, I'd be more than happy to.